now time to introduce our didactic speaker of the evening, Dr. Wafula Nalwa. Dr. Nalwa is a physician and a cardiologist with several years' experience. He is the founder and CEO and Chief Medical Officer of the Kisumu Heart Center, a specialist center for clinical, preventive, and rehabilitative cardiology and cardiometabolic medicine. He is a Bachelor of Medicine and Surgery graduate of the University of Nairobi. Dr. Wafula Nalwa also holds a Master of Medicine degree in internal medicine from the same university. He is also passionate about teaching, and he is also a holder of a fellowship in cardiology from the Yashoda Heart Institute of India. He has previously taught at Maseno University. His presentation will last 30 minutes. So will you all join me in welcoming Dr. Wafula Nalwa? Dr. Wafula Nalwa, the floor is yours. Karibu.
Hello, everyone.
Good evening.
Yeah, can you see me?
Yes, good evening, we can.
Good evening, we can see you well.
Thank you. So I will do a presentation on hypertension in Sub-Saharan Africa, what we need to know, and some of the important things we need to do in terms of practice and even policy. Next slide. Hello.
We can hear you,
So this gives us, this gives us a snapshot of the burden of hypertension around the world. If you look at all the regions of the world, it's around 22%. However, in the least developed countries, you have accelerated development of cardiovascular disease because of demographic shift, nutritional transition, meaning that people who are living in rural areas, people who previously did not have access to certain risk factors, are now getting access to those risk factors and are developing hypertension. And so the least developed countries in South America, Africa, and Asia have a huge
Dr. Nalwa, you're muted.
Okay. This is a slide. This is a slide that highlights the disease burden in a place like northern Tanzania. If you look at the blue color up here, you will notice that chronic diseases are accounting for a significant portion of the burden of disease in a very, very rural part of northern Tanzania. Then there are issues that are complicating the cardiovascular disease burden. For example, COVID. You can see in that diagram there, down here you can see disease mortality, CVD prevalence, and hypertension prevalence. If you look at the first column, you can see pink. COVID mortality seems to track CVD prevalence and hypertension prevalence. And so areas that have a significant burden of NCDs look like they are going to be affected significantly by a number of these emerging challenges. And therefore, all facilities need to be aware and to be prepared and to invest in the management of hypertension. Now, in Africa, it has been found that elevated systolic blood pressure is a significant cause of mortality. Systolic blood pressure, anything above 140 is elevated blood pressure. And if it is tested on different occasions and remains elevated, it should not be excused. It needs to be diagnosed as hypertension. Elevated systolic pressure also accounts for more than half of the first-time acute stroke, and it's considered to be a modifiable risk factor for dementia. Of all adults that have been studied across the continent, it's found that about 55% of people older than 55 years have hypertension. And among those who are under that age group, around 30%. Therefore, it's a growing problem in poorer households, in rural populations, in younger people in whom it's more aggressive. And urbanization is not helping much, because the changing of the diets, the changing of the settings of physical activity are aggravating the situation. So what is the definition? Generally speaking, we talk about 140 over 90, or someone who is on treatment. But there are different groups of people who have had classified blood pressure. We have the Americans and we have the Europeans. And they have different cutoffs and gradings that we all need to be aware of. Just a minute, sorry. Am I doing the right presentation? Something seems to be amiss here, but no problem. Generally speaking, we talk about optimal blood pressure below 120 over 80, normal 120 to 129, high normal 130 to 139, and then we start grading it as grade 1, 140 and above, grade 2, 160 and above, and then 180 and above. And this is very important because we need to know that we need to be quite aggressive in treating hypertension, and every millimeter lowering of blood pressure is significant, has a mortality and morbidity benefit. There are determinants of hypertension. When you look at a group of people who have hypertension, when you look at communities of people who have hypertension, there are certain factors that you cannot change, and there are certain factors that you can change. So when we talk about age, sex, heredity, ethnicity, those are things you cannot change, and you must always capture them in the history when you are interacting with a patient. Or when you are considering a patient to have hypertension, you must always think about these factors. And then there are other modifiable risk factors that are related to lifestyle, including salt intake, sedentary lifestyle, mental stress, and the like. Types of hypertension. When you are managing a patient with hypertension, it's important to know that we have essential hypertension, which has no attributable cause. The most common factor related to essential hypertension is age and gender. But then we have other types of hypertension that are related to disease entities that a patient may have. For example, a patient who has hyperthyroidism, a patient who has chronic kidney disease, a patient who has a tumor. So whenever you find someone who has hypertension, you need to try and delineate. Is this patient having essential hypertension or secondary hypertension? Someone who develops very severe blood pressure under 35, for example, or above 55, for example, very high blood pressures, you may need to consider if they have a secondary cause of hypertension. And the secondary cause of hypertension on its own is a target for treatment. That's why you need to find out what is the underlying cause for it. Hello?
Yeah, Dr. Wafula, you may now use our...
Yeah.
What we have, yes.
Yes, yes. Okay. So please scroll up. Please scroll up. Okay. Again. So we've talked about essential and the determinants of blood pressure, modifiable and non-modifiable risk factors. It's important to always have this in mind when you are managing whichever patients that you have. Next slide, please. We've already addressed that. Next slide. So why do we worry about hypertension? Why do we worry about hypertension? This slide summarizes the reasons why we are concerned about hypertension. That uncontrolled blood pressure, elevated blood pressure, is associated with heart disease, it's associated with stroke, it's associated with myocardial damage and heart failure, it's associated with brain dysfunction and memory issues, it's associated with kidney disease, it's associated with blindness, it's associated with peripheral arterial disease, and therefore it's one of those issues that must be addressed significantly. Many times when we talk about medical complications, we do not give it the of what hypertension really is. If you look on the level of your source of productivity, if you have a stroke or heart failure, will not be able to engage in economic activities as should. Dependence. There's a reverse of dependency. Providers start becoming dependent people. There's increased cost of care when you have complications. You can imagine the cost of that. And that cost of care is actually impoverishing families. Therefore, it's important to be very careful in making the diagnosis of hypertension, to be very careful in instituting appropriate treatment and timely titration to target for these patients. Next. So what do we need to do? What do patients need to do? What should be our approach to managing patients who have hypertension? There is a big component that is related to lifestyle. Studies that have been done in Kenya, for instance, among the Maasai community, who are a nomadic community and who used to trek large wide expanses of land, about 50 years ago, there was no documented case of hypertension. But their habitats have been invaded by urban areas. And right now, the prevalence of hypertension is very high, as highlighted in the northern Tanzania area, which is the territory that the Maasai used to traverse. And so issues to do with diet, salt content, alcohol intake, physical activity, mental stress that comes with urbanization and globalization, weight challenges, smoking, and even access to treatment are all factors that need to be addressed when you're dealing with hypertension. So what do we need to do? We need to change diet. We need to change our levels of physical activity and stress and manage a healthy body weight. Next. For medics, when we interact with our people, we need to assess and score them. So remember, we talked about hypertension. We talked about the stage of hypertension. Stage 1, 140 and above. Stage 2, 160 and above. Stage 3, over 180. You need to look at what kind of risk factors do these patients have. 1 to 2 risk factors or greater than 3 risk factors. anytime you have greater than 3 risk factors in a patient who is in stage 1, and then it means that you need to consider them as high risk, depending on the blood pressure here. If you can look up here, compared to stage 1 and complicated hypertension. Then you have asymptomatic disease, and then you have stage 3 symptomatic disease. So any patient who has renal disease, has elevated blood pressure, you can see how we need to address them. We need to be very aggressive to lower that blood pressure. You have a patient who has cerebrovascular disease and kidney disease and long-standing diabetes. They become patients who are at very high risk of complications, and therefore they need to be managed quite aggressively. So scoring a patient, putting together the risk factors will help you to understand that patient and to be able to manage them. Now, to do this, it means that we must be able to empower our nurses. We need to empower medical officers and clinical officers. We need to reorient the training so that they can be able to understand what this is all about. Next. How do we then do assessment of patients practically? The first is history and examination. Every day in my practice, I see patients who have hypertension and have been told it is not so severe, it is not so high. Let us check for malaria, let us check for typhoid. It is never considered that hypertension on its own can cause patients to be unwell as they come to hospital. So always have it at the back of your mind in people who are older, who present with any nebulous symptom. Actually, these patients, in the examination, it needs to be part of the vital signs that are considered significantly. Secondly, we need to consider be able to score their cardiovascular risk and therefore to see how aggressively we need to manage them. If a patient comes with leg swelling, facial puffiness, or if a patient comes with features of thyroid disease, then investigate it. If a patient comes with heart disease or heart failure, you need to investigate it. If a patient comes with a stroke or a transient ischemic attack, you need to investigate it so that you understand the true state of that particular patient. Once you've listened to the history, you've examined, you've been able to distinguish between various factors, then you can propose a treatment for that particular patient. Next. So the most important thing you need to have is a blood pressure machine, a very good listening ear, and careful examination. Management of patients who have hypertension needs to be individualized. It needs to be looked at in the lens of cost and sustainability. Options available for treating people with hypertension include lifestyle, we've alluded to earlier, pharmacologic therapies, and there may be surgical interventions. Next. We have already alluded to these issues of weight, calorie restriction, salt restriction, increased fruit and vegetable consumption to help us with micronutrients and potassium, increased physical activity for cardiometabolic fitness and calorie management, quitting smoking and alcohol use, and management of social and occupational stressors. Next. Now, one of the ways I like to illustrate the approach to treating hypertension is to look at your own legs or your own hands or your own paired organs. That for you to be able to function, you have the two paired organs. Patients present to be introduced with one drug, but eventually they need to not enough. You need to pair it with lifestyle management. So drug and patients will end up requiring 2 or more agents. add an agent, do not hesitate to up-titrate the dose of the drugs that we have. Us to use. The main classes of medication behind diuretics or thiazide-like diuretics. We have calcium channel blockers. Calcium blockers include nifedipine, amlodipine, angiotensin converting enzyme inhibitors. We have angiotensin receptor blockers. So group I class. D, we have angiotensin, angiotensin converting enzyme inhibitors include drugs like Nalwa. It's not which in your countries you may find and group. Beta blockers include atenolol, carvedilol, bisoprolol. Mineralocorticoid drugs include dacton, eplerenone. So you need to know these classes of medication so that you can choose them accordingly. It's an important thing for us to know. There may be newer drugs in each of this. When you are selecting the drugs, it's important to consider cost and availability. Not the latest, not the most fancy name, but one that works. So is it available? Is it affordable for long-term use? You can use fixed dose combinations. For example, if a patient is on losartan and thiazide, you can reduce the pill burden by combining two drugs. You can consider what are called compelling indications. Indication means that those have particular value in surgeons and tend to enjoy that. It's important to consider the adverse events. Because you comes looking a lot, ask yourself, is it the drug that is contributing? In elderly patients, electrolyte imbalance is important. If there's change in mentation, that means they are becoming more drowsy and the like. Ask yourself, there's an important factor also to consider is dose titration. Generally speaking, I see patients who come to see me with an enalapril at 5 milligrams, for example. 5 milligrams is not, once a day is not sufficient to control markedly elevated blood pressure. You should be able to increase it to 10 and even to 20 in a day. All the way to 100. So I like to have a drug index close to me. Every time interacting with patients, I have a drug index I can refer to, or ensure that I'm able to titrate the doses correctly. This is this is part of the presentation of compelling indications. So Black patients will need a diuretic plus a calcium channel blocker in their treatment for effective treatment. You cannot use enalapril and lozenge together. You are going to have side effects. Patients who have heart failure will need an SE inhibitor or an ARB, a diuretic based on their volume status. They may need a beta blocker, mineralocorticoid antagonist because of their mortality benefits. So you may need to combine them in heart failure. For chronic kidney disease, we've talked about the renoprotective effects of renin-angiotensin system inhibitors. And then patients who have diabetes should be generally treated like patients who do not have diabetes unless they have proteinuria, but there is a protective effect of SE inhibitors and ARBs. So there are compelling indications. Whenever a patient comes to you, ask yourself, what are the unique features that this patient has and which drug confers advantage, a therapeutic advantage. Next. Next slide, please. Looking at this slide, it gives us an indication, a snapshot of trend targets that we need to have. Just like all of us, when we set off on a journey, we need to know where the look at this age bracket here, 18 to 65. If you can reach 130, for older patients, you may be a little liberal to 139. Is a fair target for all the patients. For various reasons, I have found it difficult to bring it to below 100. There are several barriers to blood pressure control, which we all need to be aware of. Access to treatment, reluctance to change lifestyle, failure to take medications as indicated, for whatever reason, lack of regular side effect of a drug, for example, erectile dysfunction, inertia, function of knowledge, communication barriers, or non-compliance to treatment, whatever it is that contribute to poor control. So we need to be aware of that. Next slide. There are also surgical interventions. We have focused on them, but for thyroid disease, there is a solution. For adrenal tumors, there is solutions. Then there are policy interventions. I mean, sitting in a clinic or sitting in a hospital to manage hypertension is easy, but there are macro level issues that affect our ability to control pressure, that affect the incidence and prevalence of hypertension. For example, you look at the community and where you stay. Are there a place for children to stay fit and to control their weight? Are there safe roads for people to jog or to cycle? Are there safe neighborhoods for people to wake up early and do physical activity? When you go to the supermarket, who controls the amount of salt and sugar in food? How do we support people who want to stop alcohol or cigarettes? How many people know that 55% of people over 55 years have hypertension and something needs to be done? When was the last time you attended a seminar on hypertension funded by NGO or funded by a donor agency? You do not see a good pool of competent HR, and that's why I applaud Project TINA. Then cost-effective medications. There's a tendency for medical practitioners to run to the latest, which are more expensive medications. I have found pure delight in using cheaper, older drugs to manage our patients and controlling their blood pressure. So access to cost-effective medications is important. At policy level, we need to ensure this is available. We need to increase awareness of disease. And then community engagement and participation in control. NCDs have looked like an elite group of conditions, but it's a big problem that requires communities to work together to conquer it. And I believe that we can do that. Thank you very much.
Thank you very much, Dr. Wafula, for this superb presentation. I'm sure we are all better informed. Clearly, nutrition plays a major role in the prevention and management of hypertension. Without further ado, I'd like to invite Mrs. Fumi Ijiwola, one of the hub experts and a nutritionist by profession, to share her thoughts with us. Over to you.
Okay, thank you very much. Good afternoon and good day all. This slide, as Dr. have already stated, that nutrition is playing a very great role and is a teamwork, and it also involves us also sending these patients down to dietitians so that they can see them as a whole, and then so that we can manage the patient well. So because of this, we just have few points. I don't know if you have the slide with you, Ma. Hello, can you hear me?
Yes, I can hear you. Let's have the slides.
I have a slide, Fred. Do you have it there?
Yes.
Okay, can you just show it so that everybody can go along with me? So what we just want to emphasize on is that we need to understand that over 70% of the dietary sodium we are talking about comes from eating packaged and prepared foods. So that means we work on what the patient is eating. So, and then we also need to now make sure that we need to find a way to reduce how that packaged food should be reduced in their diet. So what is the recommendation? Like 2 teaspoons. That is not so easy, but we just have few points on how to easily achieve that, so that you have this thing to always tell your patients on how to achieve low salt. One, we are saying that they should make their food on their own. They should eat more homemade food, because when you go to restaurants, they are not considering whether you are diabetic patient. All they after is the taste, and for the taste to come out, they must meet up with most of the population. So they're not considered of reducing having low sodium or not like that. So the patient should eat more of homemade food, and that is better. Then the habit of forming the habit of putting salt discourage all the time, and at the same time, we should always advise them to make sure that salt should be the last thing they put when they are cooking. So that will be able to allow the reduction in their salt use. So number 2 point is for them to season and to rinse it. You encourage most of the patients to have more of natural herbs and spices to enhance the taste of their food, like them including more of onions, garlic, ginger, and thyme into their food, so that will taste. And at the same time, for any canned food or vegetables they are taking, because most of the vegetables and fish are being preserved with salt and then oil. So we always encourage that they at least rinse it out before they use, and they reduce any form of canned food or cubes. Then you also advise them to eat fresh. Eating fresh saves them from using much of the salt, and clean. So eating fresh and unprocessed fruits, vegetables, whole grain, cereals, and meals. Then patients should learn to read labels. You having 140 milligram of sodium in your food or in any food you want to buy is higher. So they should learn to always reduce it. So what are the practical tips you need to tell the patient to increase their fruits and vegetables? Now, the actual recommendation is you having 5 or more fruits and vegetables. So how do you achieve that? You achieve it by starting.
You're on mute, Mrs. Fumi. You are on mute.
Wow, sorry. Okay, so all you just need to do is practical tips to increase your fruits and vegetable. So that means you need to always emphasize that, okay, make sure you have a favorite food, even if you have a favorite food, but make sure you pair it up with fruit or vegetable. So the number 2 tip is to always add fruits to your cereals, such as porridge or oatmeal instead of sugar. So because we also want to control the calorie, so we also need to also make sure that we have more of micronutrients in their diet, and at the same time increase the fiber in their food. So it's a very good way. Fruits and vegetables can be used to increase the fiber in their food, and at the same time ensure more micronutrients. So putting it in their cereal is an ideal thing to do. So we also try to encourage to bring fruit and vegetable as the on-go snacks. When they want to snack, the first thing they should think of is fruits. They should have carrots in their bag, cucumber, garden egg. You don't need to cut them. So they should always have it as a snack to always eat. Then they should always ensure that lunch and dinner are served with vegetables. This will help them to increase the number of servings they have in the day. The last one, use vegetable as the main ingredients. Now, we can always make sure that something like giving an example of rather than having high ingredients. So the last point is for you to use fruits and vegetables to garnish your food, to use it as a topping, as a sauce, or as a filling. So we must also emphasize that this is very important, just like what doctor said, that vegetables like terere, water leaf, manuga being added to the meal is very, very important in management of this hypertension. Thank you.
Thank you very much, Mrs. Fumi. I'll take a few questions, and there are a few on the chat. If I can read out the first one. Over to you, Dr. Wafula. Why should the systolic blood pressure not go below 120 mmHg for an individual less than 65 years with hypertension and or diabetes?
There are studies that have been done about tight blood pressure control. So there are what we call points of inflection. There's a point of pressure at which you derive a benefit. So the management is not primarily about the figure, but is about the benefit of a particular level of blood pressure control. That's number one. Number two, for you to be able to bring someone, for example, from 160 to 120, the pill burden is likely to be very going to be, and the cost of care is going to be very high. So if you consider the cost of care, if you consider the risk of side effects, if you consider the morbidity, mortality risk of very, very tight control and organ dysfunction, then you do not want to go below where evidence shows benefit.
Okay, thank you for that. And there's another question. A client with generalized edema and BP of 120/100 should be managed. How do you manage such a patient in a primary healthcare level?
That's a patient who requires evaluation. The question is, why do they have generalized edema? One of the commonest causes of someone to have such significant fluid retention is kidney disease. You can have pure kidney disease. You can have a mix of cardiac and kidney disease. Okay, you can have a mix of pulmonary, cardiac, and kidney disease. So that's a patient who cannot be kept at a primary care level. That's a patient whose care needs to be escalated. That patient will require renal evaluation. That's a patient who will need cardiac evaluation. And that kind of evaluation is not very common at the primary care setting. So it will be important to notice that it's a severe patient and refer them to where they can get care.
Okay, thank you, Dr. Wafula.